Welcome to the Healthy Lifestyles Podcast, located here in Northwest Phoenix, Glendale, and Peoria. My name is Dr. Nick Hunter. I am a doctor of physical therapy, and I own and operate Preferred Physical Therapy, where we have helped hundreds of people aged 40 plus stay active, independent, live free from painkillers, and avoid surgery, even if they've had pain for years. I have written over 8 ebooks on how to treat common injuries and hosted numerous webinars, all in an effort to help educate the public on how to care for and maintain their bodies to live with joy, dignity, and without compromise. This podcast is intended to help you make better decisions about your health so you can find joy in the journey by bringing together top healthcare providers, fitness experts, and nutritionists in the area to give you the knowledge and confidence needed to make good health decisions. Thank you for joining us today.
The whole point of this seminar is to answer questions about back pain. What is it? Why does my back hurt? Why does it continue to have recurrent episodes? Or why do I have a constant ache that I don't seem to be able to get rid of? I'm not a fan of injections, pills, or the possibility of a surgery. Hi, Eliana, how are you? And so the whole point of this is just to hopefully shed some light on what options exist in terms of better understanding why your back may be in this case and what you can do about it. Again, I showed this earlier. These are my boys, my wife and I. We're going to be 19 years 2 days from now, so super thrilled about not forgetting that. And these are our boys. My oldest, the tallest one in the middle, he's a senior. Be graduating. We'll go to Liberty High School. The second tallest is Jackson. He's a sophomore. They're both taller than me now. He's 15, so the 15 and 17-year-old are taller than me. And then Jacob and Alex. Alex is the black shirt here on the far left. He's the baby, and he's definitely your typical baby, your youngest. It's never fair. It's never right. It always wants to try and keep up, but also recognizes he's quite younger than all the others. So it's a lot of fun. A few facts about back pain. Come on in. Good to have you. A few facts. We're just getting started. You're totally fine. One of the most common causes of disability, especially job-related disability, what you're going to notice is that over the course of anyone's lifetime, 80% of Americans are going to have an episode, at least one, of back pain. 80%. It's an enormous number. Not all of it is required to have medical attention. You're going to see, as many of you have noticed, have had back pain episodes. A lot of it goes away in a week, 2 weeks, maybe 4 weeks. It goes away. It's not terminal. It's not one of those things where you feel like once you get it, it's like, oh, I've got it. Nothing I can do about it. Not that way at all. In fact, it's very treatable. It's most likely occurring for folks between 30 and 50 years old. But then we see higher incidences of, if you're not 30, it's okay. If you're a little longer than 30, it's all right. Just most commonly, that's where you find it, okay?
It's okay at 30.
It's a different story now that we're over. Right. But this is one thing that I hear from a lot of folks, and I get really concerned about this language, is like, oh, you got back pain, it's your new normal, nothing we can do about it, you're going to have to deal with it the rest of your life. That is just sickening to me to know that there are folks out there, providers out there, medical professionals who have limitless amounts of data and research, current, ongoing, and even past. I mean, I'll show you some data that is years old that continues to support an active lifestyle. And still some providers will suggest that there's nothing you can do about it, just live with it or take some pills and have it go away, and that's just, it couldn't be further from the truth, which is why I love doing these kinds of things. Before we get into too much, I want to go over some anatomy. There is some very interesting aspects, truths about anatomy that is worth knowing in terms of what does it help you do then to say, okay, this is something I can deal with because I have a better understanding of anatomy. The spine, the lumbar spine, is made up of 5 vertebrae. Come on in. It's made up of 5 vertebrae. And the lower lumbar vertebrae are the ones that we're talking about. So if we put our hands in our hips, think of it like our pelvis. We see those hip bones. Right across the hip bone is we're going to find L4. L4 is the one that doesn't quite sit on the sacrum, but sits right above it. This is L5. Right above that is L4. And L4 is right about the level of the hip bones. Okay, so we'll notice we have that flat bone here, hip bones, and then up 5 vertebrae. When we say vertebrae, we're talking about the bone, just the bone structure itself. And what we're going to see is this next slide is a much easier one to see. Okay, push a little harder. this is a much easier representation of the vertebrae itself. This is the bone here, and this is looking top down. So if I peel all that back, looking top down on a vertebrae itself, this is what it looks like. This is the back side. This is the more weight-bearing or load-bearing feature of the spine itself, and that's really what the spine does, is it bears load. It supports us vertically. And then you have all these little bony wings, and these bony wings are real fun. Their whole purpose is to attach to muscles and ligaments. So there's those bony wings here are what help support and give anchor to all our levers and pulleys. Muscles are just that. These are anchor sites for those as they pull down to then provide some mobility and movement. Right here, on top of this, like a sandwich, is a disc. So this is a better site here where you can see where vertebrae stack, and in between those vertebrae, those bony vertebrae, is this mobile disc. And that mobile disc is what gives us our flexibility. It's also why, as we gain in wisdom and knowledge in this earth, that we then get shorter. Because those discs are what narrow, those discs are what shrink a bit, and we lose some of that height.
Not fair.
Not fair.
No.
Not fair. We're going to talk a lot about discs. Welcome, you guys. Thank you. A lot about discs because we get a lot of concern, a lot of lack of clarity. Hey, Gilbert, come on in. Around the fact that discs are one of those things that can herniate, they can bulge. What is a bulge versus a herniation? And how do they contribute to episodic disc pain, which is recurrent pain, where it's like feeling good for a long time, and then all of a sudden I do something, cough, sneeze, bend over just wrong or whatever, and then I'm down and in like 2 days I just can't move, then 4 to 6 weeks of pain, but gradually improving, and then I'm back to normal again. That's disc herniation all day long. So we'll talk more about that. The other unique thing about the disc is it provides space. Remember these wings here? This is what they look like from the side. And you see this little gap right here? That's the space for nerves to come out. This is the central canal of where the spinal cord exists. And then we have these wings of nerves that spread out called spinal nerves that then go out and feed the extremities. So same thing happens in the neck. They feed the arms. In the back, they feed the legs. This space is hugely important to preserve and to maintain. We lose it when this disc height begins to shrink, again, as we gain in wisdom and experience on this earth. But what happens is that then clamps down and decreases in space, making it less room or less space for those nerves to exist. There's also a few other things that contribute to that. We can get some callus formation. I say callus. Callus is like bone spurs. Callus for the skin, same kind of thing happens for bone. It's called a spur. When that tends to happen, again, you get less space across there. Sciatica, nerve stuff going down the legs. We'll talk more about that in later episodes. Any questions about some of this anatomy? This is like straight from the back. If you're looking straight at someone from the backside, this is what you're going to see. You all can run your finger down your back and feel those bony spots going down. That's these spinous processes right here. It's a big site of muscle attachment. You'll feel as you run your hand down, those bony spots just to the side of that are big muscle bulks, big valleys of muscle, and those are hugely important for spinal stability. We'll go over that just a little bit. Going back to nerves, the reason why back pain can be so daunting, scary, terrifying is because we're dealing with nerves. And nerves are not the greatest of healers. We get quite frustrating actually because we go through, things will get better, but nerves just take forever to heal. And anytime we start running into damage to those nerves, we get really concerned about how permanent or how long-term that damage is going to be, which is why it's so important, why we advocate so rigorously is early intervention, early care versus waiting. So often we grow up because as youth and how quickly youth recover, we remember healing so easily, so quickly. And then we get into our 20s, 30s, 40s, and 50s, and like, any day now, I'm going to recover. Any day it's going to get better. And the reality is we just don't quite recover like we used to. We don't quite heal as quickly as we used to, and why it's so important, and instead of waiting that time to get early intervention, to get those things cleared up so we don't run the risk of putting those nerves at any kind of compromised position to run the risk of long-term or permanent damage. And that's where it gets concerning. A few of the main causes of back pain diagnoses of back pain. I thought about putting a few more slides in here, and I'm like, I just need to slow it down. Back pain is divided into two groups. You have non-specific, and you have specific. Specific is 10% of the entire population of back pain. And when I say specific back pain, we're talking about tumors, infection, fractures. Those are really the main ones. Like just the things that you need immediate intervention from, not physical therapy, chiropractor, or exercise. We'll go over those things. But those things need immediate intervention. 10%. It's a low number. 90% is what we call non-specific. And these are all non-specific. And I know it's confusing because we have diagnoses for these non-specific mechanical back pain categories, such as stenosis, spondylosis, degenerative disc disease, degenerative joint disease, arthritis. Those are all just similar kinds of forms to say it's arthritis. But those are all still considered mechanical, non-specific low back pain. And that's everything that we do to help treat and take care of. The other 10%, the tumors, infections, fractures, not us. The 90%, that's what we can do, and these are all parts of it. Sciatica, herniated discs. Herniated disc and disc bulge, anyone know the difference? Trick question, they're the exact same. Fracture and a break, what's the difference? Trick question, the exact same. The only difference between a herniated disc and a bulge is the degree or grade at which the disc is herniated. Herniations, 3 categories. You got a bulge, then you have extrusion, and then you have sequestration. Just 3 types. There's no quiz on that later on. Just understanding the fact, most commonly, bulges, very, very common. Probably all of you under 30 have one. You guys probably are okay. Everyone else, some degree. Everyone else, probably some degree of disc bulge somewhere. It doesn't mean anything. I'll show you a study here later on. I'm getting so ahead of myself. The fact that herniated discs, disc bulges, are just another way to say, this is what we found on an MRI. You can't see them X-rays. This is what we found on an MRI. You have a herniated disc or a bulging disc. It does not explain your back pain. They did a study. They pulled 100 people, 30 plus. 40 of them had herniated discs, no back pain. 40, no back pain, but on an MRI, herniated discs. So just because it's there doesn't mean you have back pain. We recognize that it's there. There's some things that we want to work on, things that we can do to help make sure that it stays kosher and fine, but does not mean that you're going to have back pain or that you're cursed with back pain. Just understanding what spondylosis and stenosis are. Spondylosis is just another way of saying a degeneration or narrowing of the spine is typical and very normal, average wear and tear. Very easy to compare it to like tread on a car, tires on a car or shoes. The more you use them, the more those things tend to break down. Now, biologically speaking, we repair, we recover, unlike shoes and tires on a car. However, there is, to a degree, an amount that we don't fully recover or fully repair, and that's where we get into those kinds of things where we can call it spondylosis, we can call it degenerative disc disease or joint disease or arthritis. It's all the same way to describe a fancy wear and tear of the body. Now, does that mean that there's nothing that you can do about it? Because I hear that, oh, it's arthritis. Nothing you can do about that. Another myth I want to debunk later on. Absolutely, there's thousands of things we can do with arthritis, and the Arthritis Association of America continues to suggest and strongly urge people to stay active and to seek physical therapy care for treatment of arthritis. Stenosis is unique. This picture really shows it the best. You can see under normal conditions, that canal where the spinal cord exists begins to narrow and constrict and tighten. These are the folks that you'll see in a grocery store. They lean over the grocery cart. Oh, my back feels amazing when I lean over and push on that grocery cart. And that's because as we get into that flexed position for the spine, it allows that spinal cord to have more space, and it just takes away all their pain. All my stenosis folks, this is what they look like. They're typically 60s and older. They have really tight hips. They're going to be bent like this, and they're going to walk this way, and they extend, and they can't quite get to extension. They all say their pain comes down just below their rear, and it's like stenosis all day long. Easy to see, really easy to classify, almost always that way. Tough to treat in extreme cases. early signs of stenosis, the best things you can do is work into gradual extension, meaning that you want to stay into extended postures, find your way into extended postures. What do we find ourselves doing in America 40 hours a week? Sitting at a computer. And what position is sitting for our spine? Flexion or extension? Flexion. We're sitting in a flexed position for long periods of time, encouraging this kind of adaptation. Our bodies are fantastic at adjusting and adapting to what we do, what we impose on it, what we demand on it. It's called Wolff's Law. It adapts based on the imposition or demands of its environment, which is why there's a lot that we can do if we impose new demands. But if we find ourselves 30 years in the future and then say, oh man, I wish I would have done something sooner. We hear that so often. I agree, I wish you did. But 10 years from now, your 10-year-old self is going to say, I'm really glad I did something now. So that's stenosis, degenerative disc disease or degenerative joint disease. We're actually, as a medical profession, trying to go away from these things because they're fancy ways to describe a thing that is just so common and so regular, so routine. We start saying things like this and it triggers fear and anxiety in the patient to think, oh, I'm cursed. And it's not, you're not diseased. You're normal. You're aging. It's what happens. The day we're born, we recognize that hopefully we get to advanced ages of life. That's our goal, is to make it there. We can make it there in various degrees of ability, and that's where we're trying to help folks understand there's so many things you can do. So calling these things degenerative joint disease or degenerative disc disease, we're trying to go away from this because it was a fancy way to describe what we're noticing as just normal wear and tear. There are mild, moderate, and severe grades of this that can play a part of that, but at the end of the day, I really want you to feel comfortable knowing I'm normal, this is okay. There's a lot that can be done to mitigate that continued progression. As we age, we notice that we tend to start to gradually hit this decline. It takes longer to recover. I'm not as strong as I was. I don't have the energy like I used to. I'm not as well balanced. Things are weaker. Totally normal. Does that mean that we have to continue on that perpetual decline? No. There's a lot that we can do to encourage changing that angle, changing that rate of change. So it's not like a rock in the ocean, but we can start to lengthen out those days. We've all seen the folks who, wow, you look great for your age. They're very mobile, they're doing whatever. And a lot of us just think, oh, genetics, lucky guy, lucky gal, whatever it is. I will argue to a point that's true. There is part of genetics that can play a part. There's a bigger part, a much larger part, where these folks have just done a much better job of managing, whether that's activity level, diet, and a matter of addressing multiple levels of fitness or conditioning that assess the age-related joint stiffness, age-related muscle decay called sarcopenia, which is just the normal loss of muscle or strength as we go on, and a continued amount of aerobic activity to keep the heart healthy. When the heart's healthy and blood's pumping, things have a chance to heal. When it's not, they don't, which is why we continue to, you want to get 150 hours a week, 150 minutes a week of aerobic activity. We want your heart beating fast for at least 150 minutes a week. And the reason for that is it perfuses the body. We get oxygenated blood and refreshed blood circulating throughout the body. I'm going to go through a few studies. I'm getting way ahead of myself. Going through a few studies about showing the primary care protocol, meaning when you go to the primary care physician, the protocol now for low back pain is stay active, take some over-the-counter pain pills, and come back in 2 weeks if it's not better. That is like the route. I got a backache. All right, stay active, don't lay down, take some over-the-counter stuff, come back in 2 weeks if it's not better. Because previously, what was it? Oh, lay down for a few days. That's the worst thing we can do now. We've debunked that. It's just like, how many of you remember when your parents put butter on burns? Horrible idea. That's not what we shouldn't do that anymore. We used to cast everything. You have an ACL surgery, which is very common now. They'd cast you up to the hip for 6 months. 6 months. We're up walking day one because we recognize just how important, how quickly our bodies adapt to those new demands of now immobility. What does that leg look like coming out of a cast after 6 months? Pretty much bone. How hard is it to get all that strength back? That's why it used to be a career under. It wasn't because the ACL wasn't fixed, it's because now we can't get that muscle back. And so you want to go run? It's going to take you 2 to 3 years to recover instead of back to NFL level playing in 6 months. That's what we're at now because of how much better we are just knowing how the body works. I've already talked a little bit about herniated discs. A few unique features about herniated discs. Think of it like a jelly donut. This is not the greatest example, but jelly donut. In the middle, we have that gelatinous deliciousness, for lack of a better word, in the middle. But it's a shock-absorbing structure that also allows for more mobility. The outer rim, the outer rim is all annular fibers, and think of it like a really tight woven mesh ligament fiber. So very strong connective tissue that keeps it together. It allows us to be mobile because of that shock-absorbing middle, but then the outer fibers are rigid and firm. What's great about that is it does give us a lot of mobility. It gives us a lot of shock-absorbing capability, but they can bulge or herniate. And what happens is those annular fibers begin to tear and weaken, and then that middle gelatinous, it's called the nucleus pulposa, jelly of the donut, then begins to push into that weakened area, and under bad circumstances, that's called the sequestration, is that jelly will then leak out into the spinal canal and then come apart and leave and then float into that spinal canal. That's worst case scenario. Also not always guaranteed surgery because the body will absorb that, clean it, get it out. Not guaranteed surgery. Under some circumstances it can be, but not guaranteed. Going back to what the typical bulge is it's common for those annular fibers to weak. No symptoms. They're okay. No symptoms. Doesn't mean that you're cursed. It means that you're normal. Lots of things that we can do then to help reabsorb that and strengthen that disc. Again, they will heal. Discs will heal. I want you to understand that. So many folks don't believe that because they've been told by other providers who are looking for long-term gain on your behalf that it's not going to get any better, you're cursed. That's not true. You are not cursed. That will heal. You will get better. It does mean you have to get a little bit more diligent and more aware of what you're doing, but you will get better. We see it all the time. All the time. It's documented constantly. Radiculopathy, consistent with herniated discs. Going back to how I said there's that space of the vertebrae where the nerves exit. Well, commonly the disc will herniate into that space. So if I go back, you can see in this picture here that red that's that annular fibers that are coming apart and then weakening, and now there's space for it to push into that spinal canal where the nerve exits, and it's causing or contributing to pressure on that nerve. That's where it's really important when you start having back pain and it's like zingers down the leg. We all have been calling that sciatica, and a lot of times people think, oh, it's a sciatic nerve. It's the nerve like from my butt all the way down my leg. It's like, yes, that is where the sciatic nerve goes, accurate. Where the problem is in the back. There's a rare condition called piriformis syndrome that can, in isolation, irritate the sciatic nerve. It's just not very common. And like almost 90% of all those cases are from the back. And so we see that all the time, and that's where we call that a herniated disc or radiculopathy. It means it's radiating pain. Apathy is just any kind of condition. And that's where you'll see it. Does that mean you're cursed and you won't get better? No, you're not. You will get better. We see this all the time. Herniated discs causing radiculopathy, even pressing on the nerve, can still get better without surgery, especially if you get in quicker. The longer this goes, the harder it is to take care of, and possibility of permanent damage, because the more that nerve is choked from that disc, the greater the chance is that that nerve won't fully recover. So you'll see this a lot of times when people with a foot drop. It's like I'm walking and it's really weak now. I try and pick up my toe, or I trip on my rug or the threshold of my door. I feel like I can't pull my foot up. That's a very common pattern because of L4, L5. Those vertebrae I was showing you at the lower lumbar level are the ones that are most commonly herniated and most commonly irritated on the nerves, are those levels. And so you'll see it in the foot a lot, sometimes bottom of the foot burning, those kinds of things. You'll see people who are like, I can't pull my leg straight all the way. It's because we're pulling that nerve all the way from the back, and it's restricted from that movement. Going back to sciatica again, common sites of where you'll feel that pain: back of the leg, back of the knee, calf, again, sometimes bottom of the foot. Very common sites. This is a top-down image right here. It's really hard to use a mouse. I'll just keep pointing. Top-down image, again, if I'm pull that away and I'm looking straight down on my back, that's what that looks like. There's the jelly donut. You can see where the deliciousness is in the middle, outer rim, where it's bulging and pushing pressure onto that spinal nerve. Different than spinal cord. Spinal nerve is where it exits, and causing some of that pain going down. Again, these are the red flags. So these are the specific causes of low back pain. Red flags. So what we'll do during our examination is rule these things out. Anytime we have concern about it, it's like, okay, we need additional help. I've only had one patient with a tumor, and we did one treatment with her, and it was like, that's not the way it should have responded. You need to go get an MRI. Got an MRI, tumor, surgery, 2 weeks, good. Like, great. Pain was all gone. It was a tumor right at the disc. So they cleaned it all up, pulled it all out, and she's great. The other big red flag is neurological, let me go back, neurodeficits in the very bottom. So nerves, the way that we classify the degree of concern is sensation. If you have like altered sensations, like buzzy, tingly, feels like ants running on my leg, that's level 1. Level 2 is numb, I don't feel anything. And then level 3 is loss of motor control. So now it's like foot flopping, or legs giving out. We'll see that sometimes. That's level 3. Those are like, okay, that's more concerning. Let's go get that seen. Which is why you don't want to wait until you get to that point to be, I need something done. The minute you start feeling that, you need to get treatment sooner rather than later. And here's what's deceptive about that is just because you'll have that, you may not even have back pain. I've seen this several times. My back doesn't hurt me at all. I just have this stuff going down my leg. It's like, okay, well, we're going to look into your back because this is what's going on. It's bizarre. It can totally happen. The body is very unique. Everyone's a little bit different in how that presents, but that does happen. We've had a lot of folks who have all the pain in their back, feel nothing down their leg, but they're getting weakness. I don't have any pain. I feel nothing down that way, but they'll get weakness. It's unique. So just keep an eye on those things. Other things that are things that I wrote down in terms of what we see typically, and from what the research is suggesting, folks who are affected by back pain the most. The most common picture of who is it that experiences back pain, typically 30 to 50 years old. It increases in how frequent it is as we get older. You're typically inactive during the week, but maybe more active on the weekend. Maybe you go for hard walks or hard hiking, go for a long run, maybe you cycle or play racquetball, whatever on the weekend. And because you're not as consistent throughout the week, we tend as we go along to gain weight. And you maybe have a more physical with a lot of bending and lifting job or a sedentary, more seated job. Those are kind of the end of the spectrum. And then if there's any history of mental health, interesting. Anxiety and depression folks tend to have more issues with back pain. And then one thing that we're noticing more and more is backpacks, which is interesting to me. So I feel like nowadays we're doing less with textbooks and more with computers, but our kids' backpacks are getting heavier. And I'm not sure how this is working, why it's going in that direction, but they are. And our kids just aren't built to lift and carry around 40-pound bags. Not like, ever. Maybe some of you who did the uphill both ways in snow with no shoes, maybe some of you could do that. I'm not sure, but kids today, not so much. So ideally, no more than 15 to 20% of your kids' body weight in terms of what they can physically lift. So debunking myths. I get it all the time. I got this back pain, but you can't do anything until I get an MRI or an X-ray, right? It's like, no, time out. There's actually loads that we can do. We'll go over what imaging. So we're going to debunk about imaging, MRI, X-ray. When is it appropriate? When is it not? Also, I just need core strength. Just need to strengthen up the core. Who knows what the core is? Yes, you made the motion.
Yeah, it's your.
Knees to nipples, everything from knees to nipples all the way around, core strength. We'll go into a bit more depth as to what that is, what does it look like, and even some of my favorite exercises for those things. And it's not something that physical therapy can help with. I hear this all the time. Oh, I got this thing, but physical therapy can't help with that. And the one that we hear all the time is, I tried physical therapy before, it didn't work for me. I tried it before. It's like saying, oh, you tried broccoli, you didn't like it, so now all broccoli forever is never going to work. Got it. All right, so MRIs, imaging, x-rays in general. X-rays will not show discs. They will not show muscles. They will not show ligaments or any kind of soft tissue. They will exclusively show bone. That's it. So if it's not a fracture, x-ray is no good. X-rays will show arthritis, which is normal. They can see arthritis on joint surfaces. They also can get some understanding of disc height. And the reason why disc height is important is because we notice, so you can see the difference here, this in the middle bones, right? This is CT scan, MRI, but you can see how these are healthy disc heights, where there's some gap there. Gap, pretty even gaps all the way down. X-rays will show this can be much narrower, much smaller, and that can be an issue. We can get pain at that site. We can also be worried about radiating pain, but none of that's definitive, because if we pull 100 people, 40% will come, 40 of them will come in and say, I've got no back pain, no problems. Oh, okay, well 40 of you have herniated discs. It's not conclusive enough to say, how are you moving, what muscles are productive, what movements are painful. None of that is present in an MRI or an X-ray. And that's why it's not gold standard except for that 10% of specific low back pain for fractures, tumors, even some infection on MRIs can be seen. We get a lot of folks who come to us and they'll say, I've had terrible back pain, but my MRI was normal. Anyone had that before? We've had that so often, and they're frustrated. These people are angry. It's like, how does it not show up on the MRI when I'm in such terrible pain and I have been for so long? How is it normal? They're confused and a lot of times very frustrated with that. And again, I try and say, it doesn't tell the whole picture. It doesn't show MRIs, X-rays, none of it can show pain. Pain does not show up. And that's okay. I just want you to know, just because you may have had an image or feel like you need to have one, it's not going to be one of those things that's like going to save the day and now we know what to do. It's not at all that way. This is a breakdown. You can see where as we get older, these diagnoses show up on an image. Disc bulges, herniation, signal loss, disc height, protrusions just one level higher. Arthropathy, we didn't even go over facet joints. They're just the winged portions of the vertebrae that then communicate with the vertebrae above and below it. So they're just part of the joint. Again, going through pain, we're noticing more and more pain is a whole lot more complex than just a breakdown of tissue in the body. It's far more complex. We know that because I can go in there with an injection and take away all the pain and inflammation with numbing agents and anti-inflammatories, and we can still get pain. It's far more complex than just tissue damage. The other thing about images is the reliability. This is a study that I continue to highlight because it was interesting to me. A group of radiology students, so radiology are those who read radiographic films, MRIs or X-rays. A group of students were questioning, as they're going through learning how to do readings of images, what would happen if we had an image of the person who's like a picture of the person whose graph I'm reading? Does that do anything differently? And this was fascinating to me, and it's completely changed the way we practice in here. And what happened was, you look at these radiologists who are at a computer all day long, fluorescent lit room, talking to nobody all day long, going through images, making notes on what they see. When we do the same kind of thing, but put an image of the person, of whose radiographs that they're reading, the accuracy and detail of their reports went up. just by humanizing their work. It was fascinating. So much so, it's now standard practice in radiology to include some biography or photo of the person because of how much more detailed and accurate the readings were of their radiographic images. There's a lot of subjectivity in how you might read an MRI, how I might read an MRI, and how you might read an MRI. If we're all radiologists, study different schools, we'll see same things, but interpret them slightly different. And that was going on. It's totally normal. My personal experience, I broke this wrist playing basketball, had an MRI done because the orthopedic surgeon was concerned about some ligament tears. Had the MRI came back, oh, that was clean, that's intact, this is intact. So the orthopedic surgeon said, all right, great, I know we're going to fix the bone, put it back together, I've got a plate and screws, good to go. 4 weeks later, I came back and I was like, this ulna right here was just wobbling. And I was like, that's not normal. And he's like, no, that's not. You should see a hand specialist. Went and saw a hand specialist. Puts the graph, oh yeah, you tore your TFCC right here, which is a soft tissue ligament structure that on my MRI said was intact. And I was like, you said that in 2 seconds. I handed you my thing. You look at it, oh yeah, it's torn. And so I went back to Simon Med and I said, I want you to reread this because I have a conflicting report from this hand surgeon. And the director over there is like, oh yeah, we missed this. We're not going to charge you for that MRI. Thanks, appreciate it. Had to get casted for another 10 weeks. Luckily, that where the tear was is a spot where there's a chance, because there's blood flow in the area, that it would heal by itself. And it's done a pretty good job. It's not totally better, but it's done a pretty good job where I didn't need to have another surgery. But I was frustrated because I could have gone, it had been torn, and then found the right guy to fix everything at once. They were already in there fixing stuff. It was a mess. Might as well have had it all done at the same time, but because we relied on a poor read of an MRI, it didn't get done. So humanizing the whole healing experience is vastly important, which is why in our model here, 30 to 60 minutes of undivided attention is what we give for our patients. If you've been treated by us, you'll know your entire first phone call intake process is probably the longest and most, what can feel like cumbersome experience, just because we're going to give you the whole 9 yards of what is going on for you, what do you want to get back to, understanding everything about you, so that we know when we come back here for treatment, I know what they want to get back to doing, why this is impacting them, why they're so frustrated, what they're wanting to create, what do they want to produce on the back end, because that helps us dramatically in our accuracy and our diligence to do right, to do what's best for you, versus 10 to 15, maybe 20 minutes of typical routine, regular physical therapy kind of time with name, date of birth, insurance. Okay, we'll schedule you in 2 weeks from now. You come in, I know nothing about you. I've got 15 minutes to figure it out, and then I'm on to my next patient. How in the world is that going to be the best chance for physical therapy to fix you? The label of physical therapy didn't work for me. Okay, did you get that kind of physical therapy? Because I can understand how that's not going to work. Versus 30 to 60 minutes of undivided attention and nearly a 20-minute phone call up front with our team before we even see you. It's a very different experience. Surgery, we kind of went over this. I'm going to go through this quickly because I'm rambling, to be quite honest. Just real quick, conservative treatment, just so you know. Primary care, you get your prescription, or you get your first checkup with your doctor about, hey, I got back pain, what do I do? Stay active, take some pills. This is typically the route it will go. Ideally, here's how it should go. Ideally, take some anti-inflammatories, stay active. Here's a referral for physical therapy if it doesn't improve in 2 weeks. So then you can just go get started with physical therapy. What tends to happen is pills and rest is prescribed, no improvement, specialist for injection, temporary improvement. Oh, it feels amazing with the injection. I'm going to go do everything I haven't been able to do. And I've been now resting for 6 weeks, usually at this point. What do you think is going to happen to those muscles? Much like a cast, if I've been resting and not using them, they get weaker. And now I've got the pain gone. I'm going to go do everything I haven't been able to do. The yard work, the laundry, the cleaning, the up and down. And then my back is sore again. I do 3 rounds of injections. We won't do any more than that because we know it cortisone steroid injections cause damage after 3 times within a 12-month calendar year. After that, you go radiofrequency ablation. Oh, okay, we'll just go in there and burn the nerves that give sensory input to the disc. By burning the nerves, your pain will be gone. What else does that burn? The motor component to those core muscles that are responsible for giving you support through your back. Guess what's going to happen next? You're going to, after that, still have pain and then need surgery. Where if we insert physical therapy much earlier in that process, the chance of you avoiding surgery is far greater and outcomes are much longer lasting. I know that exercise is not for everybody. And I know that everyone's understanding of what exercise is widely different. Some people will say exercise, oh, I'm not running marathons. Right, that's not exercise. That is one form of it, but it is not what I'm prescribing. And so, to Christy's point, there are some doctors who think she's probably not going to like exercise, and so I'm going to do this other thing instead. When if you say, what about physical therapy? Would you write a referral for physical therapy? Yeah, great. I mean, if they're a doctor younger than 50, they know that the right thing to do is activity. Older than 50, you may have to advocate a little bit more because it's just so common to write the prescription for pills and then refer out to a neurospecialist or to a back pain specialist that's going to lead down to ablations, injections, and surgery. So I added this slide in this week because this has been around for a long time. You have specific and non-specific low back pain. Specific is the 10% that require more advanced medical procedures than this is your infections, your fractures, your tumors. And then you have non-specific low back pain. 90% of all other recurrent back pain episodes fall into treatment categories of 4 types, and these are them. 4. It's quite simple. However, let me back up because it's not like that simple. There is some in between where folks will fall into different categories, more than one. For the most part, though, we've done a really good job, and I learned this when I was in PT school in 2010 because one of the authors of this entire study made it her life's work, Julie Fritz. One of our professors at the University of Utah was responsible for writing this up, and it's been adopted by the Journal of Orthopedic Physical Therapy, and it's been widely purported as the gold standard treatment guidelines, not recipe, but treatment guidelines for these 4 categories of individuals. Chiropractic care. Do we as PTs like chiropractors? We're fine with them. We are okay with chiropractors. They fall into this manual therapy category. Spinal manipulation is appropriate. It is an effective and accurate tool to be used under this specific category of back pain episode. The occurrence of pain is within 16 days. You don't have any radicular pain past the knee, and you're not afraid of having your back cracked. Like, great. A manipulation is one thing. Now, is it going to be the thing? Cracked, fixed, you're done? No, we know that, but it does stand a place in treatment and management of low back under those circumstances. The people who do best with a spinal manipulation, which we are taught to do in physical therapy, and we also do, is under those conditions. Typically, it's under 50. Not always. We've blurred the lines of the age, only because typically younger folks aren't as afraid of having spinal manipulation done. We get a lot of folks who are like, I just don't want them doing that. All right, then you are not a candidate for it because when you're tense and it won't work. And that's totally fine. But those are the things, like, it has a place in medicine. It absolutely. Do not get me wrong, I'm not in here to have a battle with chiropractors because what they do has a place in medicine. Yes?
Regarding that, prior to coming here, went to 3 or 4 different chiropractors. And the last one before I started this program, he would do a strap here.
Yeah.
Is that good for you?
Yeah, I've heard it called the ring dinger, and I don't know. I'm gonna be completely honest. I don't know. When I watch it, I'm equally shocked.
Yeah, it kind of angered me because it was like you're laying there and you're expecting, him to
something somewhat gentle, or
Yeah, he just yanked
wham.
the strap and it just
I guess it's
felt
okay
it
if you're
rip
gonna hang
my whole
yourself.
spine.
Right. And so I don't, to be completely honest with you, I don't know. What I do know is spinal manipulation is effective under these circumstances. That it does, for the most part, if you've had joints cracked and you like it, it does give you a short-term analgesic effect, which is a pain-relieving effect. And I say short-term because it is within minutes to 24 to 48 hours before it's like, okay, I need another one. And that's it. That's what it is.
That's the first time I've ever heard of something like that.
Oh, it was scary.
Yeah, it's a strap. It's a Y strap they put around your chin, and okay, relax, boom, and it's a big yank. It does do a lot of decompression for the entire spinal segment. It can be overwhelming, where you just feel like a lot just happened.
Because many years ago, I was in chiropractic for quite a few years. And I could see what it did do and didn't do.
Yeah. Again, when you have, then there are great chiropractors. There are great PTs. And then there's the other side of the spectrum for both professions, no question. And under the right application, under the right circumstances, phenomenal care. I don't know about that particular manipulation.
Yeah, I don't either.
Good question, though.
Why don't you let it? Why don't you tell him, I'll try this on you and see how it works.
Yeah. Let me see.
I wanted to.
So the other three categories are ones that we see the most of, and I put it in this order. I put it here on purpose because you'll see manual therapy or manipulation and traction are on two ends of the spectrum, and then in the middle are the more active forms of treatment, where it's a lot more understanding of what needs to be strong and stable and what needs to be more mobile. And so what we'll notice is the manual therapy and traction groups also benefit from one of the other two more active groups in the middle. And so we know under a specific exercise program, some folks in back pain will have a directional preference. I get relief when I do this, and I get more pain when I do this. Okay, so the more flexion-based activities we do, the more relief you get. The more extension-based activities, think stenosis, we do, the more pain we get. Okay, so we design a program around those preferences, keeping all your things in mind. The other thing we're going to go over is centralization and peripheralization. Going back to nerve pain, when you have traveling pain or nerve pain, we call it centralizing when the pain, sensation changes, or weakness comes out of the leg and centralizes more towards our core or the source of the injury. We call it peripheralization when it does just the opposite. If you do a move or a treatment and it's like, I was feeling it in the back of my leg, now I'm feeling it back in my knee and calf. Okay, that's going in the wrong direction. And so under a specific exercise program, we want to understand, is that occurring? I want you thinking disc and I want you thinking nerve when you're starting to hear any kind of traveling pain, centralization or peripheralization. So the same thing happens in stabilization. This is one of those very, very classic. These are your gymnasts, your dancers. These are your, those are the two most popular ones. But the folks who are just really flexible and they're all loosey-goosey. They were the ones who could do all the back bends when they were early teens, do the splits, all your super flexy people in their sometimes late 20s, 30s, and 40s. They're all coming in here a wreck. And under these circumstances where we see they are hamstring length goes above 90, so we lay on our back, your leg is straight up, and we can get above 90. And we call them aberrant movements, which are movement patterns where they're just not healthy patterns. They're tipped to a side, or you'll see them, if you put your hands in your hips, we think this is like pelvic neutral, we call it hands in your hips, and we want your thumbs and fingers to be even, straight across. I like to say, think of your pelvis like a bucket. And if I fill that bucket full of water all the way to the brim, I don't want to spill it forward or backwards. I want to keep it level. So these are folks who typically are spilling forward and then having all kinds of problems in their movement patterns. So those are called aberrant movements. And so we know those folks need a stabilization pattern or a stabilization program. And then your traction. In more recent, like within the last couple of years, they're starting to blur away the traction protocol because it's very small, specific groups, and it's just a temporary treatment. So your teeter hang-ups, your inversion tables, your traction tables with the belts and the straps and the pole, they've been doing, it's been going on for a long time, and it used to be like everybody gets that, and they were like, you know what, really almost very few people should get that. And only when we have disc injury and nerve problems and pains where it's peripheral, where it's going down, and we can do movements to centralize, and a lot of that movement is a distraction or a tractioning effect at the lumbar spine, then we will suggest some temporary use of traction with a stabilization program. But it's like that's it. Like that's all that would really benefit from traction, and we're not even really like we don't really care about doing that a whole lot. We teach there's 3 positional traction techniques that we teach, in that like we want you to be able to find those positions where you can get some of that distraction, get some temporary relief, and then what we like to do is exercise and mobilize in that traction position. What I don't like about laying you on a table, strapping you in and pulling, is you're not active. You're just laying there, and then what happens is we unstrap you, we sit on up, and guess what? Pain comes right back because now you're not in that traction. So we like to do some techniques to get you into an understanding of what are some positions that you can find some tractioning effect and strengthen and mobilize you in that moment so that you can work those muscles without causing pain or causing peripheralization of symptoms. Okay, what is my core? I'm going to go through some of these slides pretty quickly. Knees to nipples and all the way around, all that is core. So your quads and hip flexors are all part of core. Abs, everyone thinks, okay, crunch, crunch, crunch. Yes, small, very small component of core. One of the things that we teach right away is introducing diaphragmatic breathing. So your diaphragm, the muscle that comes right underneath the ribs. Big inhale, but big inhale, we don't want to see collarbone rising. We want to see belly rising. So we call it diaphragmatic breathing to introduce to you how we should be breathing. When we do so, the diaphragm contracts and lowers. And what does that lower and squish into? All our guts. When we compress into our guts, that makes that area tight and rigid, and we're able to participate in abdominally bracing our back. So then we can, without having to work on all of our back extensors, the big muscle bulks we have along our spine, we're able to give them some relief because it's not the only anchor or lever that we have to stabilize our spine and through mobility, because we are designed to move. We're not designed to have braces or rigid straps constricting our movements. We want to do so actively, and this is the way that we do that. So that's step 1. Teaching you how to breathe is step 1. And then the other thing that we go into is the transverse abdominis. So 3 levels of ab muscles. This is the deepest one. This is one that works horizontally or across. You can think of it like a girdle, like a strap. It is your built-in girdle. It's the one that runs this way. And what we like to describe doing is if you simply lay on your back, put your hands on your hip bones, and then just sneak in right here where it gets soft. Go through a few breaths, and then I want you to think about pulling your belly button down into the spine or table, and then lower. Now you should be able to hold that and breathe still. And the more that you're able to do that, breathe and hold it, the more endurance and activation you have of your transverse abdominis, which helps you then bend, lift, and twist without pain. You have a question? You're good. Okay. I'm going to go over, we're going to keep moving. You guys are doing great. So again, going through core strengthening, these are some of the things I like to spend a little bit of time on, only because we have all kinds of myths and misconceptions of what is core strength and how do I do that effectively without causing pain. Hip flexors are another big one that we keep an eye on because they originate from the front part of the spine. So remember, the vertebral bodies, or the bigger circular portion of the bone of the vertebrae, is the front part. They attach from the front, they go under all our guts, and then they anchor onto the front part of that spine. So your folks who we see that are pouring forward and really tight through the front, it's because they get really tight hip flexors and they're being pulled. So our folks who are seated for a lot of the day, they get up and they're like, oh, I got all kinds of pain from that sit to stand transition. Usually a symptom of tight hip flexors, so we try and mobilize those, and then we try and strengthen them because they're very weak. And then we go over glutes on the backside, understanding how the levers of our entire core work. So if we think of that pelvis, okay, if I have front and back and I've got strings going up and down on all 4 sides of that, we have glutes and hamstrings pulling down this way. We have our big back extensors pulling up, we have our abs pulling down, and we have our quads and hip flexors pulling down. So they're all working in concert back. Now that's okay. It's designed to move that way. That's extension. But what happens is if I'm standing here and I'm getting that extension here at my pelvis instead of here at my lumbar spine, it causes what we call reverse arthrokinematics. Not a quiz on this later, but then it changes the way those things are moving and pinching those discs in a more unnatural way when we don't have the support from the front. When we have that position in the back, we want to have more support in the front. So we want to think about our transverse abdominis, our hip flexors, our rectus abdominis, all these others on the front. And without adequate support, we don't get it. So why is sitting the new smoking? I know we're trying to debunk that. It got really popular a couple of years ago. Because like casting, what are we shutting down when we sit? Muscles, our glutes specifically, they're not working. They're not doing anything but cushioning us. What else? How are our abs? What are they doing?
Nothing.
Mostly nothing. Our hip flexors participate a little bit, but they're doing so from a shortened position because they're flexed up. And so they're not getting any kind of lengthening strength. Plus, as we strengthen them at end range, and I say strength is like we're just using them, so we're applying some level of demand to them, they get strong at end range, but then they get tight. So then we go to stand up, and it's just a big pull and tension across that low back. So why is sitting so detrimental to our core strength is because we're effectively casting them. They're casted and they're atrophying. Fast forward 30 years, how does core look now? When all we do is a few things on the weekend and then we cast them the rest of the week. It's that element of time. If we do 4 weeks of 24/7 cast, we look a certain way. If we do 30 years of 5 out of 7 days of cast, we look a certain way as well. And then you add weight gain, you add slower healing, inactivity, and it's a recipe of problems. This is a list of things that we hear PT can't fix, but in fact, all the things that we can. Everything in this 90% of non-specific low back pain is there. And then my favorite line is, oh, I've tried PT before, it doesn't work for you at that time. Just a list of the things. We have now over 108 reviews. Is it not? I think we had one last night, no comments, but just a review last night. But I love hearing the reviews of, I've been to numerous PT in the past, I've been to other providers in the past, and this was very different. Those are my favorite ones to get. Because that's exactly what we're trying to do here with folks to help them understand how different it can be. Again, kind of going back to the model of care, understanding the radiology study about humanizing their reading of the report and how accuracy went up is the same intention that we have here in humanizing your experience of pain, what's going on, why you want to get rid of it so badly, why it's so important, and how can we help you achieve that. Completely changes the way that we practice. Some of the things that we do in physical therapy, I'm looking around, I know a lot of you have been in here before, spouse of people who have been in here before. You guys are awesome. You guys know what we do in here. A lot of it is just whatever it does take to help you get better. We try and lengthen what's stiff if it's out of bounds of where it should be, strengthen what's weak when it should be better, balance and coordination, like motor learning. So just because something is strong and mobile doesn't mean you're using it correctly. And so we have to try and work on getting things that can move, that can be stable, and then how do you put it together? All things that we help do and putting it into a package is going to help you produce the outcome that you're looking for.